Good afternoon, everybody, and thank you again for joining us for another one of our wonderful free medical specialist seminars. Today, we have the very lovely Dr. Ken Ingram, who is an optometrist, and we'll be talking about optometry medico-legal case studies. Now, Dr. Ingram has been with MAG for a little while, and he brings to us well over 30 years experience, including many years experience doing medico-legal work. He has also been a member of the Optometry Board and has officiated over matters to do with approvals of qualifications, disciplinary matters and other matters in relation to optometrists. So his commitment has been on maintaining the standards of the profession to the highest standards possible. His area of optometry key interest or focus is the functional aspects of vision correction. So put it simply, are glasses or contact lenses really necessary? He is an expert on all things optometry, and we are incredibly pleased to have him today and very grateful for this presentation. May I please ask that you remain on mute through the session. If you have questions to ask, you can type them in the chat or wait till the end of the session, and there will be time for questions at the end of the session. So without further ado, over to you, Dr. Ingram. Thank you.
Perfect. Thanks so much, Michelle, and for your technical assistance as well as the kind introduction. I'm just going to put that's working okay, Michelle, my screen sharing?
Yep.
Perfect. Yep. Okay. So, look, as Michelle said, I'm from optometry. I suppose I'm part of a fairly small profession in the big scheme of things, and I believe I may be the only optometrist on the Medico-Legal Assessments Group panel, but it's definitely a real privilege to present today and perhaps break some new ground and represent my profession. As Michelle said, I'm the profession of optometry. We've probably got about 5,000 to 6,000 practitioners in Australia. We've only relatively recently become involved in medical or therapeutic eye care, probably in the last 20 years or so. Prior to that, the scope of our practice was mainly the correction of vision with appliances, with spectacles and contact lenses. But the scope of practice has increased quite substantially, which puts the profession, I suppose, a little bit more in the crosshairs of medico-legal action. It changed probably about 20 years ago because we as a profession were granted access to therapeutic goods. So we're able to write prescriptions for topical medications for the eye. We don't write scripts for any systemic or oral medications, just eye drops only. We have a fairly small number of claims and issues, probably compared to our surgical colleagues in ophthalmology, but it's definitely increasing with that scope of practice changing. As Michelle said, I'm a member of the Optometry Board of Australia. Specifically, I'm a member of the Registrations and Notifications Committee, and I suppose in conjunction with my colleagues, I read an increasing number of cases about late or perhaps misdiagnoses to do with non-surgical medical eye care, as well as problems with perhaps spectacle or optical prescriptions, and sometimes some other issues as well. So I suppose I'm well aware of the potential issues at play in the profession moving forward. You can see some of the memberships there. It's just a quick introduction. I have a special interest in contact lens fitting and consulting, particularly for quite irregular corneas. And I'll have a case that I'll present to you in just a couple of moments about one of those. I also do what's called orthokeratology fitting, which is a particular type of contact lens for the reversal of myopia or short-sightedness. I'm also involved in a couple of research studies, one with the Queensland Institute of Medical Research, which is on the genetics of glaucoma. So I'm quite heavily involved in that. I'm also involved in a couple of artificial intelligence research projects, one with QOMR and another one with a group called iTelligence. That's essentially to do with machine learning. So we're basically teaching computers to analyze scans of the back of the eye and assist with screening for conditions such as glaucoma, macular degeneration, diabetic retinopathy. So the AI movement hasn't missed us as a profession either. So I suppose in my experience, medico-legal issues arise for optometrists. They can probably be broadly categorized into four main categories. The first is primary or non-surgical eye care of the red eye. As I said before, most of the surgical management of eyes is by our colleagues in ophthalmology. But acute red eyes may refer to things such as foreign bodies. These are often referred to us by local GPs. So that's acute injuries where people have foreign bodies actually enter the eye. Quite often tradies are most prone to those sort of injuries. We also deal with vitreous or retinal detachment, which have acute onset. Quite often, again, GP referrals. These can be quite sight-threatening. In fact, I had a patient only this morning, a couple of hours ago, who had some vague sort of symptoms, had a retinal detachment, which will require same-day surgical management. So he'll be probably in surgery tonight. Some of these can be very sight-threatening if they're not attended to quickly. We also deal with sudden onset diplopia, which is basically double vision. So that can potentially indicate problems with neurological pathways. Sometimes can be life or vision threatening as well. We also look at the therapeutic mismanagement in eye care. For example, there may be situations that I've seen where a misdiagnosis of a particular condition can lead to the wrong management. A good example might be the prescription of steroid eye drops on the eye for someone who has a herpes simplex infection of the eye. So incorrect sort of management of primary eye care. I also deal at optical and prescription spectacle lenses. So I look carefully at the implications of incorrect prescribing relating to both the prescription and the appropriateness or the type of the appliance chosen. For example, some people with multifocal lenses may have difficulties if they have postural or musculoskeletal or balance issues. So that's an important area. I also look at the post-operative visual rehabilitation. So people who may have had surgical treatment for cataracts, perhaps corneal transplants or refractive cases, which is to correct vision in the eye, and also post-traumatic or concussion issues. There's also increasingly just the adherence to visual standards. I'm often called upon to make judgments regarding the fitness of my patients to drive a car or potentially fly planes. This can potentially cause a lot of high emotions and potential conflict because obviously as people get older, they lose their independence if they lose their driver's license. So that can certainly be a potential conflict, and sometimes legal action can take place if people think they are fit to drive and they'll seek second opinions. So the first case, to just, I suppose, to demonstrate some of the issues, I'll present a couple of real cases. The first case is regarding a post-operative rehabilitation, where I was asked to provide an opinion on the visual and refractive outcome of a corneal transplant surgery performed by an ophthalmologist. So the cornea essentially is the very front surface of the eye. This particular patient was a 40-year-old male. He had a condition called keratoconus, which is a genetic or partly inflammatory eye disease where the cornea becomes extremely thin. That may be as a result of persistent eye rubbing from allergy or potentially atopic dermatitis. The thinning can cause the central cornea to protrude quite significantly, which causes a lot of irregular astigmatism and quite poor vision. So you can see from these diagrams here a case of keratoconus. The bottom coloured photograph there is what we call a corneal topography map. So it actually measures the shape of the eye in quite intricate detail. You can see that the red areas are areas of high curvature or high, very steep areas. The cool colours, the blues and the greens, are areas of low curvature. So this cornea was quite irregular post-surgically. The surgery itself had a satisfactory medical outcome, but quite a poor visual outcome. And I suppose that can be the case. Even eventually a corneal transplant can be required to correct these conditions because the cornea is so thin, it's at risk of perforation. The surgical procedure is called a penetrating keratoplasty, PK. A donor cornea is actually used to replace the central part of the cornea over the pupil, and it's sutured to the peripheral host tissue. So, as I said, this case had a satisfactory medical outcome. So the eye was wide, it was comfortable. There were no signs of any immune rejection. The cornea was physiologically healthy, but there was quite a poor visual outcome and refractive outcome. The vision was quite poor, 6 on 120, which is less than below the legal limit for driving, and in fact is basically characteristic of legal blindness. There was a lot of very irregular astigmatism, as I pointed out before. So what causes this irregular eye shape? Well, it's caused by slight tilting of the graft and some asymmetry of the suture tension. So when the graft is actually attached to the donor, to the host tissue, it's actually sutured in place. But asymmetry of the tensions of the sutures that are used to attach the graft can sometimes be slightly varied. These are continuous sutures around the full 360 degrees of the eye, and they're left in place for up to 12 months. So if one or several of those sutures are a bit tighter, the cornea can become quite irregular. So the solution, really, spectacles are not particularly useful in this case. We need a contact lens that actually vaults the cornea and creates basically a regular optical surface for the eye's refraction and therefore the resulting vision. So you can see in the picture on the right-hand side, that's a cross-sectional view. The grey curve at the bottom is the cornea. The top curve is the contact lens, and there's a gap between the lens and the cornea of about 200 microns, which is about 0.2 of a millimetre. So the fluid that forms between the contact lens and the cornea forms part of the correction. So this patient achieved an excellent visual outcome of the contact lens, 6/6 acuity, which is 20/20 vision. And really, the surgical outcome really was within quite a normal range, within expected clinical norms, given the available technology, the technical challenges of the surgery. The cornea was physiologically functioning well. The vision was able to be corrected quite nicely with a contact lens. That's not an unusual outcome for that type of surgery. So I remarked in my report that a successful medico-legal challenge against the surgeon was quite unlikely to succeed. My second case relates to judgments that optometrists sometimes need to make and adherence to visual standards. In this case, a clinical judgment about a driver's license. So I suppose a lot of these cases are not simply black and white. There are many nuances when it comes to approving people for driving and for flying. Each case needs to be assessed on its own merits. And there's rooms for some interpretation of the standards and sometimes for conditional licenses to be issued, as well as straightforward unconditional licenses. The reference standards are in a document called Assessing Fitness to Drive 2022, which I believe is available online. It covers pretty much all private and commercial standards. It may vary slightly from state to state, but as you would expect, commercial standards are higher in terms of the required visual performance. High contrast visual acuity, that is how far down an eye chart you might be able to read. That's not the only and best way of determining driving performance. We look at performance in low contrast conditions, and also we look at what's called the width of the visual field. So the two main standards that people have to meet to drive a car are visual acuity, so how far down an eye chart they can read. It refers to the smallest size lettering on an eye chart that a person can read at a distance of usually 6 meters or 20 feet. If a patient has a visual acuity of, let's say, 6/12, what that means is the first number 6 refers to the testing distance, so we test them at 6 meters. The second number refers to the size of the letters on the target. So the smaller the second number, the better the vision. So someone with 6/6 vision has better visual acuity than someone with 6/12 vision. The second vision standard is what we call field of vision. That refers to the width or the breadth of vision an individual has to see cars or to see pedestrians. That is peripheral vision, cars at an intersection, for example. Now, it's possible to have excellent visual acuity to read the bottom line of an eye chart, but not be fit to drive if the lateral field of vision is too restricted. So patients who've had glaucoma, for example, or may have had a stroke, they may have excellent central visual acuity, but have substantially reduced field of vision and may not qualify for a license. So here's a summary of the standards. From visual acuity, we need to have 6/12 vision, okay, in one eye or both eyes. The binocular field of vision for an unconditional license is 110 degrees of vision within 10 degrees above and below the horizontal midline. And there can be no blind spots within a central radius of 20 degrees of fixation. And a blind spot is defined as 4 adjacent points missed in an eye in a visual field test. I'll explain a little bit more about that in just a moment. So these standards are reasonably straightforward and relatively easy to assess in most cases. However, for a conditional license, there are more shades of grey and degrees of interpretation and room for clinical judgment. If the visual acuity is worse than 6/24 in both eyes, even a conditional license cannot be issued, so that person is unable to drive. However, if vision is better than 6/24, but worse than 6/12, so if they fall in the middle, provided there is a full width of visual field, a conditional driver's license can be issued under certain circumstances. So this is a case I had fairly recently of a 17-year-old male with oculocutaneous albinism. That's an absence of pigment in the eye, which affects the function of the retina. There's little or no pigmentation in the skin or in the eyes, generally leads to quite poor vision and extreme glare sensitivity. So the visual acuity for this fellow was about 6/24 or 6/19 with both eyes. So not good enough for an unconditional license, but better than the 6/24 required for a conditional license. So it was a case that we needed to investigate a little bit further. And in cases like this, we need to consider the field of vision, the width of vision, if that's intact, and then consider what driving conditions are safe for this particular person. What represents a risk to himself and to others on the road? So for this fellow, the field of vision essentially was intact. So a quick assessment by a process called confrontation revealed his visual fields were quite okay. This was confirmed by a formal computerized assessment, which is shown here with this picture. The dark spots in the visual field represent small blind spots around the periphery. The lighter areas on the plot represent normal sensitivity. So this patient had a small blind spot on the left-hand side of his vision, but the rest of the visual field was quite okay. The other significant clinical finding here was that he had borderline contrast sensitivity. This corresponds to his ability to see adequately in very low light or extreme glare conditions. So what do we make of all this in terms of safety concerns? So the concerns that we have were his ability to read street signs or road signs. That was compromised with 6/19 acuity. With reduced contrast sensitivity, was he safe to drive in low light conditions or extreme glare on a very sunny day or in a heavy storm or rain? If these issues could be adequately addressed, it would be possible for us to issue a conditional license. So how we went about that, we trialled what's called a bioptic telescope. Now, this is a magnifying telescope used for distance vision that can also be spectacle mounted. So in this case, it was just mounted on one side on his left eye. The field of view is too small for him to look through that full time, but our trial showed that this could be used spasmodically to briefly view distance road signs. Then for the remainder of the time, he actually looked through the regular part of the lens underneath. So a bioptic telescope looks like this in the photograph. To drive, normally the patient looks underneath the telescope through the normal spectacle lens. To see a road sign, he briefly dips his head to look through the telescope with the left eye, then lifts his head again to drive normally. So to address the poor contrast sensitivity, we use what's called transition type lenses there, lenses that self-tint automatically in the sun. And I made his license conditional on his driving daytime only, no driving in the rain. Also, he can only drive in the local area up to 20 kilometres from his home. That suited him fine, as he only needed to drive essentially to and from work. So in the end, it was a great result. Or we could keep him driving with conditions. He avoided, at least for the time being, a lengthy and costly emotional process of commencing a legal challenge. So all in all, it was generally a good outcome for all. So for my third case, I just wanted to cover, I suppose, an area that's growing in a lot of optometry practices, but particularly in mine. That's the area of patients who may be suffering the visual impact from concussions or traumatic brain injuries. The cases I see tend to be not acute cases, so it's not straight after an accident. They're more likely to occur perhaps 6 to 12 months down the track. As you'll see from this case, the visual symptoms may be subtle and not altogether obvious initially. So they're cases that often require a fair bit of spade work. So this particular case was a work cover claim. This 45-year-old male had a motorbike accident about 6 months previously, had suffered a traumatic brain injury and whiplash. He had phases of quite blurry vision, lots of glare in very bright light, headaches, especially with reading. He had some gait and coordination and balance issues with walking. Upon further questioning, he avoids going to the cinema, looking at movies. He finds the movement at the cinema and even on TV is quite uncomfortable due to some overstimulation. Initially, he had some double vision or diplopia that had now settled. So it was a challenging case. The treatment and management that he'd had so far, he had received acute care at hospital, then local care at a concussion clinic. He was still having ongoing Pilates and physio. He was having some pain relief with just medications and also some acupuncture and needling. So the interesting thing about this case and many TBI cases is that the initial clinical exam findings are really quite unremarkable at first. So this fellow had 6/6 vision in each eye, which is normal vision, minimal refractive error, didn't need glasses to that point. He had normal eye pressures. Sometimes pressures in the eye can increase subsequent to trauma. He had no recession of the angle in the front of the eye or anterior chamber injury in the eye. Sometimes concussions can cause ruptures of the iris, which can cause bleeding inside the eye, but there was no sign of that. The retinas were attached. There were no signs of any tears or breaks, and I've got photos on the right-hand side of both his retinas. His visual fields, before there was no restriction of the field of vision. So at first glance, everything looked fine. These are just slides of his full and unrestricted field of vision. Visual field assessment, essentially, it's done by having a patient look at a central fixation target. Then a stimulus of varying brightness is presented across the visual field, and the patient is then asked to respond to that stimulus by clicking a little buzzer. Each eye is tested individually, the other eyes occluded. So we get a reading and a map across both eyes. Essentially, the stimulus keeps getting dimmer in each particular point, and in this case is about 60 or 70 points, until the patient can no longer distinguish that stimulus, so it's too faint for them to see. That's then converted to what's called a threshold value, which are these numbers in the top left of each plot. So that's how we arrive at a visual field assessment. And in a lot of trauma cases, there can be restriction of visual field. For example, some people can get hemianopias, which is where half of the field in each eye is missing. That can be a sign of some sort of visual pathway lesion or some sort of injury from a stroke or perhaps a cerebral bleed. But in this case, there are absolutely no problems. The visual field was quite normal. There can also be very subtle losses of sensitivity in very specific patterns. That can indicate various neuropathies, such as glaucoma or optic nerve ischemia. So they're not quite so obvious. It's not half a field. It may only be a very small blind spot. But sometimes tumours, masses, minor strokes or bleeds can cause just quite small little blind spots in the visual field. So it's certainly necessary to assess that for every post-concussion case. So really, the unremarkable clinical findings in this case represented a bit of a conundrum. So what's going on with this fellow? Why is he having these symptoms? Clinically, there's really not much wrong. The visual acuity is fine. There's no visible eye injuries. His field of vision is completely full. So why is he having these symptoms? Why is he having blurred vision? Why does he get glare? Why does he have headaches, balance issues? Why is he so sensitive to movement? So really, I suppose the answer to this question is complex and it varies between patients. So really no post-concussion symptoms or patients can be are generally the same. So in short, the explanation for these symptoms is that what TBI or brain injury patients see is not just about what's happening in their eyeballs, it's more about what's happening along their vision pathway. So that is the part of the vision symptom between the eye, the eyeballs, and the primary visual cortex, which is at the posterior of the brain. So you can see on the right-hand side of the slide there, the vision pathway is quite long and convoluted. It goes all the way from the back of the eye, the optic nerve, to the chiasm, where a lot of the field crosses over, through a nerve plexus called the lateral geniculate nucleus, then through the optic radiations to the primary vision cortex, which is at the back of the brain in the cerebellum. So it's a long and convoluted pathway. Many things can and do go wrong along this pathway, and especially after traumatic brain injury. So a recent Swedish study of 73 patients with acquired brain injury found that 89% had some sort of visual problem. That might be reading, generally blurred vision, hypersensitivity to glare, and quite often what we call vergence-related problems. Now, that refers to issues with alignment of the eyes or double vision that this patient had immediately after his accident. And to elicit these sort of symptoms, as a clinician, really I have to ask quite specific questions and probing questions of the patient that may not necessarily volunteer this information without this probing. So some of the examples of these questions that I might ask are, how long ago did your symptoms start? In this case, it was about 6 weeks. Did you lose consciousness? No. What did your doctor say? Just give it time. Have you had brain imaging? Yes. MRI and CT all normal. Are the symptoms getting better? Well, yes, slowly, but I'm still having trouble reading. What happens when you read? The words move, they're blurred, they're ghosty. I get headaches, I get nausea, I can't retain what I read. Have you had previous concussions? No, this was the first one. Are you taking any medications? No, just for pain management. So if we don't ask these patients, quite often this information doesn't come out. So it's important to dig a bit deeper. If this information is not conveyed, potentially, as a clinician, I may be medico-legally at fault. So it is really important to elicit those signs and symptoms. So for me and many other clinicians, probably the best way of ensuring I cover off all of the relevant history is actually to use a survey. And I tend to use this one called the Brain Injury Vision Symptoms Survey. It's a scientifically validated questionnaire with scoring that ensures we don't miss the important questions. And you can see some of the examples of the questions on the slide there. It asks the patients to rate the severity of their symptoms across a number of areas, such as eyesight clarity, visual comfort, glare symptoms. The responses are then collated and scored. Now, a score of over 31 is significant for TBI symptoms. This is a survey that's validated by quite extensive research, and often I'll repeat that survey at various times during a rehab process. And the references are there if you need to sort of look that up. But the patient from this case did have a score over 31, so this was significant for post-concussion, indicated further rehab was necessary to resolve his symptoms. As I mentioned earlier, a very common finding with TBI is vergence-related eye problems. That's double vision, but also the ability of the eyes to keep an alignment, to keep the eyes straight and fused, and to keep the vision single. So the picture on this slide shows a patient converging to see the point of a pencil close into the nose. It's this ability that can be quite compromised in the post-concussion patient. So this finding is significantly higher in post-concussion patients compared to the general population. And there's also a common association between this and what's called accommodative dysfunction. So that's the ability to focus at a close distance as well as converge the eyes together. So clinically, it's important to make a distinction between convergence insufficiency, which can happen in kids, to poor convergence that's related to traumatic brain injury. So I've got a short video here. It only goes for a minute or so, but it sort of shows you, demonstrates, I suppose, the significance of eye alignment in the eyes.
Our treatment is drug for eyeglasses with small amounts of prison, which brings the image of the child. On average, our patients get almost 80% of their symptoms.
So these, I've made mention in the previous slide about the accommodation and near focus. So as opposed to converging the eyes to get them aligned and vision single. So this often goes hand in hand with convergence issues, and it's the most common effect of mild closed head injury. So it's quite ubiquitous in severe TBI, and is really quite rarely assessed or recognised by other professionals other than our ophthalmology colleagues. So really, optometrists are probably the profession that are best equipped to manage or treat this problem in the form of spectacles, quite often with what we call reading additions. So that's extra strength to help with near vision, combined with what we call prism correction, which keeps the eyes in good alignment. So this can have a very significant effect on the quality of life of post-concussion patients. It really can assist quite significantly in the rehabilitation process. And in this case, I actually managed this patient with a pair of glasses that had what we call a reading addition, plus also some prism correction built into it. So it certainly worked quite nicely for this patient. This particular slide, I just put this in from an interest perspective. It describes some of the other things that can happen, the other interesting visual phenomena that can be associated with concussion and TBI. One is which is called pattern glare and photosensitivity. So these patients find looking at people with striped shirts, or striped carpet patterns, recurrent striped patterns in carpets. They can find that extremely uncomfortable. They have to look away. The mechanism for this really isn't particularly well understood, but it's probably associated with hyperexcitability of the cortical visual system. Often people with TBIs can also get hallucinations, that is, imaginary objects in their vision with their eyes opened or closed. A variant of this phenomenon is called Charles-Bonnet syndrome. This is a condition where individuals with vision loss experience repeated visions, even though they're sometimes usually quite mentally healthy. They're sometimes called phantom images. They can include simple repeated patterns. These may appear as grids or shapes or lines in bright or vivid colours, covering everything that the person sees, or they may sometimes be quite complex images, but they can be quite vivid, and these patients often think they're really quite real. So people with Charles-Bonnet syndrome may see detailed images of even people they know, objects, sometimes animals or plants, entire landscapes. Another interesting one is a phenomenon called palinopsia. This is the abnormal persistence or recurrence of an image over time. So you can see in the photo on the bottom right here, the image of a ball traveling through space or through an arc. So people with palinopsia tend to get that retention, that persistence of a recurring image. So there's a couple of reasons it may occur. It may be hallucinatory or it may be illusionary, but quite often associated with migraine, quite commonly concussions, and also some medication. So there's some weird and wonderful stuff that these patients can experience. So back to our case, this patient had quite reduced near accommodation, so the ability to see up close was quite impaired, coupled with significantly reduced near point of convergence, so the ability of his eyes to converge and point together up close. So that contributed to his depth perception problems, some of his dizziness and balance issues. So in the end, I prescribed glasses with a reading addition. I think it was in a pair of bifocals, if I recall, with what we call base-in prism that helped maintain his convergence, maintained the alignment of his eyes together so that he could read comfortably. So really, to provide a competent neuro-optometric rehabilitation care, as a clinician, I need to have a strong understanding of neuroanatomy, experience with neurological disease, certainly knowledge and experience of binocular vision, how the eyes team together, eye movements, what causes double vision, visual field assessment, etc. But importantly, communication skills are really important for the patient, but also for their family and their other medical practitioners and associated healthcare providers. And super important, the ability to ask and to probe a bit deeper, answer a lot of questions, because sometimes these people don't know what they don't know. So we need to dig a little bit deeper. So I suppose in summary, the medico-legal issues that I encompass or optometrists might encompass include the primary eye care, non-surgical eye care of the red eye, optical and prescription issues with spectacles and contact lenses, post-operative or traumatic vision rehabilitation, which I covered with contact lenses in my first case, adherence to vision standards, so licensing people to drive or to fly, and also those post-concussion cases that I mentioned. So a few brief cases, hopefully it gives you some insight into some of the unique specific cases that I come across in times. And you can see they tend to be about vision correction with appliances rather than medically related eye care or surgical, but nevertheless quite challenging and certainly a growing area in my practice. So that pretty much covers what I've got to say. So look, I'm happy to open up to any questions that you might have.
Well, let me first say thank you so much, Dr. Ingram. That was actually fascinating. And far more, even when I looked at the slides before you joined us, that was far more than I expected to be seeing and learning today. So thank you very much. As a person with keratoconus, I actually was very interested to hear a lot about that. I actually do have a question, and that's come from someone who's unable to attend today, and that person is from an insurance company. And they asked in relation to a person who's had possibly a TBI or another head injury and or physical injuries which make them have an awkward gait or propensity to fall or for dizziness. You mentioned about multifocals. Could you talk about what are the actual concerns about prescribing those for people like that?
Sure. Multifocal lenses, and I apologize if my camera's a little bit out of focus here, but multifocal lenses are lenses that have varying degrees of power and magnification across the lens. So it's just going to restart my video. That might be a bit better.
There you go.
There we go. Multifocal lenses tend to cause, because the magnification varies across the surface of the lens from top to bottom, they tend to cause quite a bit of distortion and curving of the visual field. So people with multifocal lenses, when they look out to the periphery of their visual field through the peripheral part of their lenses, lines that should be straight, or posts, that walls or telephone poles that should be straight, sometimes have a curve. So there can be some, at least for a couple of weeks, a little bit of difficulty adjusting to the spatial awareness or spatial perception of distances. So in the TBI patient, they may have that part of their vision system or their functioning can be quite impaired anyway. So a multifocal lens may be extremely difficult for them to adapt to, and may actually make their symptoms worse rather than better. So it's all to do with judgment of distance, their position in space, proprioception. Quite often multifocal lenses can be quite problematic. So for many cases, sometimes bifocals will work better, but they do a similar job in the sense that they've got a little reading segment down the bottom. But quite often these patients do need single focus lenses and may need multiple pairs. So they may need one pair for general distance vision and mobility, a separate pair for near work and computer work, quite often with what we call prism correction, like I outlined in my case. The prism helps the eyes stay in good alignment, not over or under converge. So quite often multifocals are not indicated for people who are post-concussion.
Mm-hmm. And look, I've got one more question. I'm conscious we've gone a little over time. We need to wind up. The other question was, in relation to the 40-year-old gentleman, your first case study, why did he not have a procedure such as LASIK? Why did he go for a corneal transplant straight away?
Sure. In that first case, he had a condition called keratoconus. Now, one of the features, clinical features of keratoconus, is that the cornea becomes extremely thin. So the thinning of the cornea really means that laser or LASIK is not safe, because laser really requires a corneal thickness of probably at least 450 to 500 microns, which is 0.5 millimeter.
Mm-hmm.
A lot of people with keratoconus may have a central thickness of well less than 400, sometimes even less than 300. So laser is not safe. It will thin the cornea even more. So it puts that patient at risk of corneal perforation. So most people with keratoconus would not be suitable for a LASIK type of procedure. So his vision got to the point that even spectacles wouldn't work. Contact lenses were becoming problematic.
Mm-hmm.
So he had a corneal graft to remove that really steep central part of his cornea. It was replaced with donor tissue. Then he needed a contact lens over the top to further rehabilitate his vision.
Right.
So in answer to that question, quite often laser just isn't safe for these patients.
All right, last question here from the chat. Have you encountered people feigning or exaggerating their symptoms in the context of an insurance claim? And if so, how can you be confident in determining this?
Yes, look, I suppose from a clinical perspective, we have, I guess, a lot of the clinical measurements we take are objective, so they don't rely on patients' responses. But in terms of symptoms, particularly post-concussion, look, I suppose it's all about working with other practitioners, perhaps seeking guidance from their GP, from their general management, from their neurologist, looking at what sort of pain management they might be on, because it's difficult for them to, I suppose, consistently come up with the same baked symptoms, if you like, across a number of specialties, if that makes sense. Plus also those surveys that the brain injury visual and assessment survey is quite sensitive at picking up very specific symptoms. So there are some symptoms in there that don't specifically relate to concussions. So it's quite sensitive in discriminating that, how the survey is actually scored. So I use that quite frequently because it's quite sensitive or specific at discriminating patients with real symptoms versus those who may not have real symptoms. Let's put it that way.
Oh, thank you so much. We've got a number of thank yous in the chat there. Dr. Ingram, we are so very grateful for your time and your expertise today. Everyone, thank you for making time to join us today. The recording should get out to you later today, but it might be tomorrow. And of course, as always, it will be on our YouTube channel. And we know that our clients are watching these again and again as learning resources. So that's really, really wonderful. Look forward to seeing you in our next seminars. Of course, you know, Dr. Ingram here is your go-to man for all things eyes. And that was totally interesting. Thank you so much, everyone, and have a great rest of the day.
Thank you.